Okay. So panic disorder. As you see the old names of these, neurocirculatory asthenia or soldier heart. Well, both of them is in the beginning of this century, was from the beginning of this century, sorry, I have some. And the intensive study of the panic disorder or the disorder which was connected with the anxiety started from World War II, something like that. So as you see, soldier's heart, because that's a kind of problem were found very often in the soldiers in World War II, because at that time they started to pay attention for all these kind of problems, and they start to take care of the soldiers. And that's movements continue to develop until now, and a special impulse of the studying of these kind of the disorders started from the Vietnamese War in the United States, because they had a lot of cases of the mentally injured soldiers, but these soldiers wasn't suffering from any kinds of disorders, physical, or they wasn't injured physically, but they had a lot of psychological problems. So panic disorders goes from that time. Actually, the beginning of the attention goes from that time. And let's see what it is. First of all, panic disorder consists of panic attacks. Panic attack can come separately without panic disorder. Panic disorder is then there are a number of panic attacks following one by one. I mean not one by one without a break. I just mean that there will be more than once in a month of a panic attack. Usually it's once in a week or one in a day, but it can be one in a month, and that will be enough to turn off a patient from the normal life. So panic attacks are sudden, unexpected episodes, and they, as you see, accompanied with their physical excitement, physiological excitement. Sudden means that's a very panic. The issue, the nature of the panic attack is anxiety, very intensive anxiety, overwhelmingly intensive anxiety, so quite upper than any thresholds of that, and it develops this level of anxiety develops very intensively from normal level to the maximum, and it takes its power during 10, 50 seconds, 30 seconds. So very intense, increasing, and then there will be a plateau for 20, 15, 30 minutes, and then slowly during 5 minutes or maybe less, 5, 10, 12 minutes, it goes down. So usually panic attack takes 10 minutes, then 50 minutes to go back, 10 minutes for plateau. That you have to remember. One of the distinguishing features of the panic attack, it's a very sudden go to the down to the top, and then stable conditions for 10 minutes, and then we go down. Sometimes panic attack can be longer, but not always. Usually panic attacks, all the cycle of the panic attack takes 20 minutes, 25 minutes. So that usually people, as you see, are attacks extremely threatening. And because they occurs out of the blue, no explanation, and so people think they dying. So they call in an ambulance, and then ambulance or emergency team arrived. It's already finished. I mean, the attack. So 20 minutes. But sometimes can be more, can be 4 hours, even 2. After panic attack, after this enormous autonomic, sympathetic autonomic excitement, people experience extreme fatigue. And they're tired. Why? Because all the resources, they already spread for this panic attack. What kind of resources? It's the pool of norepinephrine in the neuronal terminals, and there is no more norepinephrine left, and that's why they feel extremely tired and fatigued, and they need time to restore these resources. So here, the main criteria of panic disorder. Yeah, it's a recurrent, unexpected panic attack, and there should be intensive discomfort, which reach peaks. See, within minutes, actually within a minute, and there will be a number of symptoms. Let me again remind you. All the symptoms, usually the symptoms of the exhaustive excitation of the sympathetic nervous system. Here, palpitation, pounding heart, acceleration of the heart rate, chest pain or discomforts. It's number 1 and number 6 symptoms. They remind heart disease. And patient really think that something happens with his heart. He's dying. He is dying from angina pectoris. He is dying from, I don't know, thromboembolic disorder, anything, myocardial infarction. So he got a palpitation, accelerated heart rate. Sometimes heart rate can be very, very high. Actually, in panic, it can come until 20 to the 200 of beats per second, 150. Sometimes in panic attack, and especially after panic attack, it's not so intensive, but the feeling, but the subjective feelings of that something is wrong with my heart is very intensive, because they experience a palpitation, not only the heart, the palpitation of the vessels in the neck, in the upper part of the face, and maybe even in temporal areas, so they feel like their heart is beating over there. It can be with an increased heart rate, but it can be without increased heart rate. Sweating, trembling, or shaking, very common symptoms of anxiety and the panic. And yeah, again, sensation of shortness or short break, of smoothing, or feeling of choking. They feel catastrophic insufficiency of the air in their lung, and then they increase their heart rate in order to compensate this insufficiency. But as we know, if you increase and you really fast, intensively increase the heart breathe rate, there will be quite opposite results. It's not enough time to change, for the exchange of the oxygen, but quite a lot of time to swipe out carbon dioxide from the blood, and we have a hypocapnia condition, and hypocapnia condition is a biological trigger of the anxiety. So we see that anxiety leads to the increased heart rate, increased breath rate, hypocapnia, and hypocapnia increase the anxiety because it gives a fear of dying, of the shortness of breathe, because hypocapnia is a signal that we have problems with our, but actually we have a hypoxemia. So practical example, practical advice. Ask your patient and do it you can do it in a directive manner. So be bold and sure, self-confident, maybe a bit pressing for the patient, and ask him to breathe slowly. Sometimes and often it's required for you to count his breathing movements, like 1, 2, 3, 1, 2, 3, 4, out. For example, breathe in 1, 2, 3, good, pause. Breathe out 1, 2, 3, 4, good, pause. 1, 2, 3, breathe in, pause, and now breathe out 1, 2, 3, 4, good. Sometimes you can put a hand on the stomach if they lay on the back, on the surface, and press. Then it should be breathe out and relax your hand and let it go up. Then patient is breathing. So there will be some discoordination in the beginning. So you have to push and then you stabilize the breathing. That's very important for the patient. Nausea, abdominal distress. I get an ulcer, doctor. I got a gastritis or anything, feeling dizzy, unsteady, lightheaded, or faint. So, like I'm going to fall down very easily, chill or heat sensation, paresthesia. So, here is numbness or tingling, but sometimes not only numbness or tingling. My friend was telling me that it's like small crocodiles are biting me on my body. Derealization and depersonalization. Derealization in a panic attack is a classical symptoms. Classical symptoms of panic and the classical symptoms of how anxiety, very intensive anxiety in terms of panic, can lead to the gray distortions of the perception of the external world. So remember yourself that maybe you was in an anxiety or intense fears. You cannot see it properly. What's going on around you? Everything is blur. It's just the symbols. It's just the silhouettes. It's just the shapes or some sort of non-focused pictures, and they have no details. They strange colors, actually no exact colors. Everything is mixed around you, and maybe you can see only something particular in front of you, like a box with the tablets. Sometimes these patients use them or take them with them. Or I don't know, you can see only the place where to sit on or to lay on. That's it. Depersonalization. Patient describe that they are in a panic condition. They don't like themselves. They don't feel themselves. They don't experience their self properly. What does it mean? That means I become numb. Sometimes they're telling you they telling me I have only these symptoms that with me, and only I'm like changed, I'm dying, I'm going crazy. That's also their description. So I'm not myself right now in this moment, and they have a feeling or condition that they go crazy or go fear of dying. These are the criteria, clinical criteria for the panic disorder. As I said, at least once in a month. Once in a month, there should be a panic episode. They and a persistent concern or worry about additional panic attack. So they're afraid of the next panic attack. All day they wait, eat and sit and wait. There will be something else. I afraid, my God, what if again it will happen? So it means so they waited. Unconsciously, of course, without their will, they expect, they worry, they are vigilant about that. Also, they have significant maladaptive changes in the behavior. What does it mean? Usually it is avoidance. Due to their panic attack, they avoid of some possible to avoid activities. Sometimes they even can stay at home, don't go for the study, don't go to work. They try to stay in a safe place. And that's meaningful for them. They change their very important plans, well, in order to avoid all these plans. They postpone them, and that's a panic disorder impact for their life. As you see, this is not because of a drug abuse like cocaine, amphetamines, sometimes ganja or cannabinoids can produce a kind of a panic attack condition. But also it's not because of the medication or medical condition like hypothyroidism, cardiopulmonary disorders, and eochromocytoma. Medical condition, sometimes because of the treatment with some drugs, with normal drugs. You can prescribe for the treatment, for example, for hypothyroidism with a hormone, with the thyroid hormones. And if too much of these hormone substituted therapy, there will be an over too high concentration of them, and these drug, these normal pills, can cause a panic attack or anxiety condition for the patient. And here it is a differential diagnosis from another mental disorder, most of course from another anxiety type of mental disorder. So panic attack and social anxiety disorder. Social anxiety disorder demonstrate itself with the anxiety or even panic, but in its particular social situation. Then patients have to make a performance, first of all. Before that, he can feel panic which stop him from the performance, run out from at home, from his home, from the conference, or from anywhere, or a patient can feel panic, then he do understand that he have to now be involved in the company or in the conversation where other people are looking at him, or maybe even they will be talk to him. I mean, other people, not familiar people, so the people who can tease him or he can laugh, humiliate him, something like that. So in this case, only in this case, these people have something like a panic. Phobic situation. So if a person really afraid of something and we take him and instantly, without any preparation, just put him or expose him for to face him with his source of fear. For example, he afraid of what? Of mice. He can have panic. Then he will instantly see the mice. That's a specific phobia in response to obsessions. In obsessive compulsive disorder, what it means in obsessive compulsive disorder we have two things: obsession, you know them, and compulsion. Obsession means I have to wash my hands. For example, my hands are contaminated with I don't know exactly, but must be COVID. Maybe not a COVID, maybe even some other kind of disease. So I have to wash my hands. That's an obsession. Okay, I wash my hands, and then it comes again and again, becoming intrusive, and it circulates in my mind and take a central place of my attention. So I'm telling for myself that I already washed my hands. I don't need to do this anymore because they clean, but again, pause. What if some dangerous germ, dangerous virus right now on it because you didn't wash it properly, so do it about once more time. And then I don't do it, then I decided, no, never I will. So in this case, if I fight with the obsession, I can put myself into the panic condition because it can be very, very intensive, my anxiety and fear. So intensive to reach the level of a panic disorder. In response or to reminders of the traumatic events and post-traumatic stress disorder. So post-traumatic stress disorder, the key feature of post-traumatic stress disorder, then this trauma, usually very, very dangerous, very, very life-threatening event, comes back again in the memory, in the mind, and attack the mind of the patient. And these forceful, unconscious, not, let's say so, unwelcomed unwelcomed memories, which are intrusive and occur by themselves in the mind, they just like predators. A patient don't want to remember, but they go again and again, and he live again and again in these traumatic events. And the traumatic events can be so intensive. So during this flashback, so intrusive, uploading, and just episode of memorizing again of these conditions. For example, I was in the war, I hardly survived, and I remember that again and again. I live in this condition, and in this particular moment, patient can experience panic, but the panic is a consequence of his memories. And the response for the separation. In separation anxiety disorder, children afraid to be separated from his mother, usually or father or parents. It can be children, it can be adolescents. So they feel real and serious anxiety, then they are out of the mother or any of the mother or another parent. So they will turn on tantrums, hysteric, crying, tears. So but they will show that they are dying, or they will die if their mother is not going to be with them. So here we have an obvious trigger. We have to just elicit it. Over the time, individual may develop agoraphobia. We already discussed that. So in this case, agoraphobia is not an independent disorder. In this case, agoraphobia is just a consequence, just a complication of the panic disorder. So approximately the majority of the patients, approximately 80% of the patient with a chronic panic attack, panic disorder, they also develop agoraphobia. Agoraphobia is, as already we told, that there's an inability to leave the place, and it's fear to be outside of the home in a condition where nobody can help you, where you alone, and there is no close friends, relatives, somebody who is your real friend or companion, and he have to be with you in order to help you. So if there will be some kind of a situation then I will be alone, or from the home, or from the possibility to take help, I will have negaphobia. I would better to stay at home. So now important stuff, it's panic disorder and other general medical conditions. Few words. Panic disorder mimics a lot of other non-psychiatric medical conditions. And because it mimics them, so first reaction of the patient is to run to the hospital. Put me in the hospital, please save me, please treat me. So they just ask only one thing, doctor, what my disease is and how should I treat it? So they go to the another general practitioner, and very often they can visit them for 3, 4, 5 times before they will be administered, before they will be referred to the psychiatrist. Why people visit not psychiatrists just from the beginning? Because they believe they have a serious illness, and it is because most of the symptoms are physical: sweating, palpitation, choking, increased heart rates, pains, or something like that. So people look for the help in other professions. And in the beginning, as you see, it's true that they fail to get good care, good treatment, because their symptoms remind physical symptoms. A doctor starts to treat these physical symptoms, and the result is not so well. Usually, tachycardia. Yes, a doctor can prescribe propranolol. It's adrenal blockators. Yes, don't work, or a very weak hormone side effect. Bradycardia, yes, but panic attacks do exist. So in this case, yes, what should we do? First of all, because panic attack can be really just an accompanying symptom of other serious physical conditions like hyperthyroidism or caffeine misuse or cocaine intoxication. So in this case, it's not a panic disorder, it's a panic attack during this intoxication or during this pathological condition. Sometimes you see an eochromocytoma or partial seizures. Complex seizures means that it's not a motor seizures, it's equivalent. So seizure, epileptic seizure in temporal lobe and parietal lobe. They both are responsible for the control. They're both responsible for the emotions. Sorry. So, in their case, that can be a panic attack. What should we do? First, it's anamnesis, medical history, and good physical examination. Then, routine electrocardiogram, routine electroencephalogram, test for the thyroid stimulation hormone if it increases. So now what's going on? Urine and blood drug screen for the cocaine, methamphetamine, and also sometimes they used blood screen or urine screening of the metabolic agents which occur after metabolizing of a norepinephrine. So we see the now after that we can see the source of the panic attack. So it must be pheochromocytoma. So we have to check him, and after that we can do diagnosis. That's one stuff with the relationship with other disorders, but he is another stuff. That's panic disorder, comorbid with medical problems. What kind of medical problems? Hypertension, heart disease, heart or cardiovascular disease. It also can be the problem of a serious brain tumor, epilepsy, or any kinds of other organic brain lesion. Sorry. When I talk to my computer, it's always very difficult. In which case, we have to react. First, if we can see a frequent palpitations. In this case, we have to be vigilant, and frequent palpitations without panic, we should prescribe a heart monitor, echocardiogram, so we have to deeply study the function of heart. And if there will be a profound confusion after attack, because there shouldn't be a profound confusion before, after, or during an attack, and actually the patient remember everything what was happening with him, who said what. But if it's too big, if they forgetting too long periods of their life, again, we should make a neurological counseling, send him there, or maybe some additional studies we should prescribe. Then you just lead a case of the patient with panic disorder, being a general practitioner. You also should check him time after time, and if you see that his course of illness is being changed, so his symptoms become atypical or just become different. So in this case, you have to prescribe additional research, and especially if there is no evidence of effectiveness of the treatment. Usually, we treat panic disorder with antidepressants, selective serotonin reuptake inhibitors, and if there is no answer in the proper time, no answer after 2 months of the treatment, wow, in that case, we should think that there may be other somatic condition also present. So now let's go to the etiology of this disorder. Genetic study found that 40% of monozygotic twins suffer both with a panic attack. 60% only one monozygotic twins suffer. So that means that it is not a genetic disorder, but genetic play an important role over here, moderate. And also here, you can see that there is the complex of the genes which can be responsible for that condition, but there is no particular indicator, there is no particular gene which we can use as the testifying indicator of the presence of the panic disorder. So we have to diagnose it by the clinical features. What also, and they found there are a number of biological findings. So there is a biological predisposition in these patients, so they develop somehow biological predisposition to react for the stressor like this, in this manner. And Pitts in 1967, what he did, he take 2 groups of the patient, one with a panic disorder, another without panic disorder, and he make an injection of sodium lactate. It's a substance which derivates in the muscles during the intensive walk. And he make an injection. People with panic disorder and people with normal, without panic disorder, they both, in the beginning of injection, they experience unpleasant sensations. So, like discomfort, like you was in a gym, even not today, you was in a gym yesterday, this morning you wake up and you feel yourself really sick, really ill, because of pain and discomfort, maybe heart rate increases. But people who have additional panic disorder, after these feelings, after injection, they start to feel panic. And same was with the carbon dioxide, yohimba, isoproterenol, caffeine, and others, not so a lot of these other substances, and they provoke panic disorder. What was the explanation of these findings? These are neurobiological changes which happens after there is a formation of the brain fear socket. So in the brain fear socket is being formed. And after that, we have a panic attack. So what is the brain fear socket? Amygdala is the center of this circle. And amygdala mediates in kind of stimuli from other, as you see, from hippocampus, sensory cortex, all the types of cortex, from sensory thalamus, all the sensory information from outside and from inside passes through or come into the amygdala. What for? Amygdala is responsible for to save our life when there is a real danger. Amygdala become excitated when there are some clues that our life is in threat, and we fight or flight. Yes. And in panic attack, amygdala become a very sensitive, very vigilant, and it's ready to overreact for any stimulus. And actually, in panic attack, a patient can see, for example, marshrutka outside in the window, and he just see the marshrutka, and then his hippocampus remind him that, oh, in marshrutka I had some unpleasant experiences with the shortness of breath. And now we have unpleasant signal, and amygdala catches. Oh, it's danger. But amygdala collect all these signals, join them together, and then give a blast of flash of anxiety by activating hippocampus. Hippocampus activates through the paraventricular nuclei, pituitary adrenal, hippocampal pituitary adrenal axis, and we have a flow of adrenaline in the blood. Through lateral nucleus, it's produce activation of autonomic pathways. From parabrachial nucleus, it is an activation of the respiration, the speed of breathing, and through locus coeruleus, also there is an activation of norepinephrine, the increased heart rate, blood pressure, and through the locus coeruleus also there will be an increasing of mental stress in our mind, anxiety in our mind. Psychological explanation of the panic disorder, it goes through the interoceptive attention or salines of body sensations, exhaustive salines or increased salines of body sensations. What does it mean? So after first panic attack or after first panic condition, patients experienced a lot of physical symptoms, blast of a physical activity, and he think, well, something is wrong with my body, I am ill with some disease, something is broken in my body. So what should I do? I should scan my body. And there is a scanning. We call it increase its interoceptive attention. And after, why is he scanning? Because he fear of fear, because he afraid that there something can happen with him, someone with his body, and he have to be ready in order to protect himself. He is scanning, scanning, and scanning, and what is the result? He make a condition for himself to feel constant anxiety because he's scanning and he finds some normal physiological or some maybe a bit more intensified physiological component. For example, if you fear of fear, your heart will be a bit increased. If you're just afraid, okay, my scanning found my heart is increased. Oh, and here there will be a subsequent misappraisal of that. So our brain starts to recognize, starts to assess this increased heart rate, not as a result of the fear, but it's as a possible result of heart disease. And what happens? Again, reaction of fear, and fear increases the heart rate. And so we have a devastating increase in fear condition, and which lead somehow to the blast in terms of appearance of a panic attack. So that is the schema. So first is a simple of less stress, yes. Emotional, some fluctuation, physical states, any substances, anything in our life. For example, you have to wake up early in the morning and have a bad mood, or today you just have a memory about it, that tomorrow there will be a test in some difficult subject and you missed a lot of classes, you have a pleasant sensation. So then you have a perception that something is changing in your body, and these leads to the not to the just explanation of normal origin of this changing in the body as the result of the stress, but here there will be misappraisal. Of course, as dangerous, all these signals are, oh my God, my heart is trembling, maybe it's a myocardial infarction. There will be an action and apprehension, increasing of the anxiety, hyperarousal, become hyperactive. And in this condition, of course, there will be perceived bodily sensation, which will lead you to, again, to misappraisal, to be afraid of the next shots on the next stroke or anything. So you wait for that, and you again recognize something which is actually fair. Actually, is nothing in common with disease, but you assess them as well. Next topic is agoraphobia. Let's make a small break. And after that, we will continue. Agoraphobia. That can be a complication of the panic disorder, as we discussed before. But it can be an independent disorder. Now we have a Micron translation, fear of marketplace. But they don't afraid of marketplace exactly. It's not their main fear. They're afraid of. And here, let's read. Situation in which patient can stay alone and can stay without possibility to get help from companion or a person who he trusts. So he very afraid of this situation. And because he afraid of certain symptoms, heart racing, troubles in concentrating on this situation. So classical patient with agoraphobia, fear, afraid that, for example, then he leave the house and go somewhere for his businesses. That far from the house, he can have some disease, some acute attack of disease. Usually, it's about heart or it's about breathing. So I will have. I'm afraid that something will happen with me, and I will die. Just or I wouldn't be able to do something, or help will be so far. So I would better stay. Why? And usually they have some. All the patients they have in the history of their relationship. They have some experience. Then they will feeling a kind of dizziness, weakness, heart problems, airlessness. So sometimes they have some kind of coma, but episodes of losing of conscience. For example, they were really tired, they were traveling in hot weather in Marshrutka, and they just lost their conscience for a few seconds. And after that, they start to believe that they have some disorder. I don't know, they don't know what kind of disorder, but they afraid that this disorder will grasp them somewhere outside of home, or will be activated somewhere outside of home or outside of a safe place, and they won't be able to help themselves. These are a criteria for agoraphobia. Agoraphobia mostly is about avoidance. So 5 or more situation. People afraid of 2 among all these 5 or more situations. But using public transportation, airlessness, it's very crowded, not enough space, very tidy. So, and train, you can stop train to go to the hospital, to run to the hospital. So everything which planes, of course, because planes just, it goes up and okay, you have some problems with the heart, but please wait until we will be in the point of our destination. Who knows, maybe before I will die 3 times of a heart attack. So they're afraid of that. They're afraid of being in open spaces, parks, marketplace, bridges. For every person being present in such kind of position is very exciting, and these excitements leads to the increased heart rate and etc. And they start to feel that they are ill again. Standing in a line, because when it will happen, then my part, then my turn will come. I don't know, I'm not sure whether I'm capable to wait, whether I have enough resources to wait and not fall down right now in front of all others with some kind of stroke. After these thoughts, it is a trigger. They have an anxiety, and this anxiety helps them to feel that yes, they are really ill and they are very close to fall down, to lose their conscience. Outside of home alone. Criterias. So individuals are fear and avoid this situation. Agoraphobic situation always provoke anxiety. Almost, let's say, always provoke anxiety and fear. So they prefer to find a safe place for them. Fear and anxiety are too big, unexpectedly. So you cannot explain their clinic. No explanation actually. And these avoidance and anxiety persist and last for 6 months or more. Here, one of the main criteria, agoraphobia causes clinical social, occupational, and other spheres losing of functionality over there. Then patient can declare you any kinds of complaints about anxiety or something like that. That's not a disorder yet. Before these complaints, before these fears, make this patient to avoid important things in his or her life, or to postpone these important things in her life. Then they impact in these areas. So this is a mental disorder. Before that, it's just strangers. Before that, it's just their tantrums, with their own wishes, caprice. And here are the symptoms of exclusion. So this is not a body dysmorphic disorder. This is not a fear or anxiety because of phobia, social situation. Actually, we discussed all this, except maybe body dysmorphic disorder. In body dysmorphic disorder, patients prefer to stay at home because they think that they are ugly, because they think that they are very bad looking person with a wrong nose, with half too big ears, or something with their faces wrong. But indeed, they have a usual normal shapes, ordinal shapes of their body, but they so strongly believe that they are ugly. And it's a sign of their mental disorder, so strongly believe, so they prefer to avoid any social contact and stay at home. Another disorder, social anxiety disorder. Should be understandable. The previous name is the social phobia. Social anxiety disorder or social phobia. It's as you see, marked fear of social situation and performance. Social situation is just a situation of conversation that you students, for example, after the lecture, you go outside in a hall and you can see that your friends, they are chatting with some others, and you go there and involve yourself into this conversation. Some of you do it easily, some of you do it with some amount of efforts for themselves, some of you are shying and they need double efforts, but some of you will be so afraid of this communication, so it's better to stay in the desk. That's very even common than the beginning of social anxiety in the adolescence, in the young age, and especially then we talk about the probable contact with the person, probable chatting, for example, with the person with the opposite sex. So if I'm a boy, I'm afraid to participate in a company which involves the girl, especially the girl that I like. And same with the girl, she afraid to be involved in this social situation. Performance situation, obvious, it's your presentation conference. And the person will panic himself. He afraid to be fail, afraid to experience fiasco, and he just telling you, oh no, next time I have to go. Why? There will be no presentation. This is a consequence of anxiety disorder. So what is the core over here? And you see, core fear is the fear of a negative evaluation. People afraid that they will be judged negatively. That other people will tease, laugh on them. And one of the conditions, these people seek for the treatment, can even do not seek for the treatment in a psychologist, do not ask for the help for long years. And that's bad because they develop the conditioned states where they support their problems. So it's a clinical diagnosis of market fear or anxiety to be in a social interaction, of having, for example, having concentration or being observed, eating or drinking. Very often it's guys who are afraid to visit public toilets. Not because everybody observe what I do in there, they just be afraid to produce any kinds of noise by which other people can understand what are they doing. Despite they do understand and realize that it's a public place, everybody doing the same, but they're afraid to show, to give some other people know that something is happening there. Or, of course, giving a speech or performing in front of a big group of people. In children, they're afraid of their peers, other elder persons, because it's normal to be shy in front of the elder persons. The children, but by shying of your peers, you can shy, yes, but not as much as it would make you feel unhappy. So individuals also afraid to show their anxiety symptoms. They're absolutely unfair in these. Not unfair, I mean, it's a catastrophe of this disorder because they're afraid of a social situation, and then at the same time, they're afraid to show that they are afraid, and it make all their suffering double, and of course impossible for in the first stage to cope with their fear. Social situation provokes anxiety, and social situations are avoided. Or a person go there like for the torture, like for an intense fear, like for the battle. Anxiety is disproportional for this kind of situation, and this avoidance lands for this. And the fear, anxiety, avoidance causes clinically significant distress and impairment in social, occupational, and both areas functioning, also emotional. Well, it's not because of medication, and another medical condition can present, and sometimes people shy of their condition. Yes, but this shine shouldn't be very, very intense. Like to make a Parkinson, people with Parkinson disease to stay at home for all his life and never to be shown for other people. No. Obesity. No. They must not be so self-restricting people. So we have in a social anxiety, performance only, and all other social situation. It's a specification. Usually people suffer from the fear of performance. Specific phobia, it's a fear or anxiety in a specific situation or towards specific objects. We already discussed all about them, so let's look at the criteria of phobia, and that can be enough. So marked fear of some object or situation, particular object or situation. And this object provokes fear always, not today, day after today, no, it's a stable condition, then first you remember about it. There was in the past some kind of conditioning of a pairing of a independent stimulus with a fear. It can be anything. Scene of blood. There should be some condition that he saw the blood and somebody died. It can be in a film. So death and blood, to see the blood and die, becoming similar for them. There is a conditioning of the image of blood with a fear of death. Now we have the fear of, now we're learning to have fear of blood. So, phobic situation make people to avoid this condition. In a phobic condition, because of these phobias, the person experience significant distress. Yes, because of the avoidance which he need to do every day, and because of that, actually he do understand that what he's doing is an unnecessary fear for this culture or something like that. So specific phobia, nothing else. They're afraid of particular stuff, and these fear make them lose to failure somewhere in some sphere, emotional, psychological, interpersonal, occupational, studying somewhere there. They, because of this phobia, they being restricted. And these are the exclusion criteria, and you know all of them: separation, post-traumatic reminders in post-traumatic stress disorder, obsessive compulsive disorder. Then you do not follow your obsession, your fear will make you worry about that. Well, everything over here should be understandable. These are the main fears of human beings. They're afraid of animals like dog, cats, or somebody else, and they also afraid of natural environment like water, rivers, where they can, I don't know, have a conditioned fear that maybe they were sinking time, I don't know, in the childhood and they're afraid of it, or maybe they were sinking in the bathroom and they're afraid of water. So water can kill. Blood injection injury, well, that's an ancient fear of blood, fear of that you was in the injured, etc. So that's almost normal fear, and situational fear and fear of other. What is situational fear? So they're afraid, for example, to be on the road because they're afraid of the cars. They afraid of injection. They afraid of vaccination, or because of the procedure. There is no blood over there, but they're afraid of it. So specific situation in the life. What is the difference between normal fear and phobia? First, specific phobia is persistent, constant. Normal fear, well, it usually occurs and then it disappears because the person has been trained not to be afraid of them. For example, in the beginning, being a veterinarian doctor, you can afraid of mice. Or in the beginning of medical scientific career, you are afraid of mice. But after you make an injection, make an investigation, you become not too afraid of that. Mm-hmm. But depending on the course, let's move further. So, anxiety, very intensive, obvious, observable in specific phobia. And usually people with fear, we do not practice, especially on the persistent in the regular basis to avoid a situation that they're afraid of something. So there is no systematic avoidance in the people with normal fears. Of course, disproportionality of the fears, and the main things: avoidance and problems. Problems are consequence which give a negative experience for the patient for his life later. Okay, so here is the next topic.